Fellowship in King Fahd Medical City. So today, Dr. Dosri will talk about rules of radiology and venous thromboembolism with no further delay. Let's welcome Dr. Abdullah.
Assalamu alaikum jameen. So hopefully over the next 30 minutes I'll be talking about the imaging techniques for diagnosis of thromboembolism in the non-pregnant population. Then we'll also touch on the imaging of venous thromboembolism in the pregnant population. So the objective is to identify the importance of proper clinical scoring index, especially from emergency room, review of the literature supporting CT versus VQ scan, and the imaging of patients suspected to have pulmonary embolism, illustrate the technique of multi-detector CT and some of the imaging findings and artifacts, some of the new techniques introduced for the imaging of pulmonary embolism, and also discuss the venous thromboembolism imaging during pregnancy. So clinical workup for patients suspected of having pulmonary embolism. Stable patients should always follow a sequential diagnostic workup, including clinical probability assessments such as Wells and Geneva scoring, D-dimer, and MDCT or VQ scan, depending on which is more appropriate. We'll talk next about the Christopher study published in JAMA in 2006, which was done on more than 3,000 patients. So this table shows that patients with low clinical probability and a normal D-dimer study have less than 0.5% incidence of symptomatic venous thromboembolism. And in patients with a normal CT angiography, they had less than 1.2% incidence of venous thromboembolism, which is quite low. So patients with low clinical risk for VTE and normal D-dimer usually have very low incidence of venous thromboembolism, and you may not need to do imaging of the chest to rule out pulmonary embolism. And if you do an imaging of the chest in a patient with clinically suspected pulmonary embolism and it turns out to be negative, then you effectively ruled out pulmonary embolism. I don't need any other further imaging study. So I'll leave this, the modified Wells criteria for my colleagues to discuss it furthermore, but it's a clinical scoring scheme where PE is considered as likely if the scoring is more than 4, or unlikely if it's 4 or less. If it's more than 4, it's considered as likely. If it's equal to or less than 4, it's considered as clinically unlikely. What's the role of D-dimer in the screening of these patients? Unfortunately, D-dimer may have low specificity and a positive predictive value. It has a very good sensitivity in general, depending on the location and size of the pulmonary embolism and the type of assay used. Normal D-dimer is sufficient to exclude pulmonary embolism in patients who have low or moderate pretest probability, depending on Wells scoring. If it can be helpful in reducing and eliminating unnecessary examinations and therefore being more cost effective. So based on the Christopher study, a workup algorithm is proposed, which suggests if the patient is suspected to have pulmonary embolism, they should go through a clinical scoring, for example, a modified Wells score. If pulmonary embolism is unlikely, then a D-dimer should be performed. If it's normal, you don't need any further imaging studies. If the D-dimer is abnormal, you may consider MDCT or VQ scan. If a patient, based on the modified Wells scoring, has high suspicion of pulmonary embolism, then you don't need to do a D-dimer. Just go ahead immediately and do an MDCT. The role of multi-detector CT in the assessment of patients with pulmonary embolism is increasingly being the first imaging modality, especially in the non-pregnant population, with a sensitivity going as high as 83% and specificity more than 96%. and a positive predictive value of around 96%. This is based on the Pipette 2 study done in 2006. Some of the advantages, it can help you eliminate other alternative diagnoses that can explain the patient's symptoms. It covers a larger area with just one breath hold, and it has very good spatial resolution and can detect even small peripheral emboli in the subsegmental regions if done in the right technique. It has high inter-observer correlation, and it's readily available in most hospitals. The limitations, it involves the injection of iodinated contrast, which can lead to renal impairment and may be contraindicated in certain situations, such as contrast allergy or renal insufficiency. It's not portable, so you cannot do it bedside. And it requires precise imaging techniques, so we need adequate training of the technologists and also adequate training of the physicians to interpret the examinations. MRA can be used in certain situations, but it has its own drawbacks. For example, in 25% of the time, the quality is suboptimal due to respiratory motion artifact, abnormal hemodynamic, pulsation artifacts, and so forth. But in general, it has very good sensitivity and specificity if it's done in the right technique. Advantages, there's no ionizing radiation, but unfortunately, it needs specialized hardware and software with trained technologists and also trained radiologists to help to interpret the examination. There are certain new techniques still under research, such as real-time MRI sequences without breath holding, and fibrin-specific contrast agents that can be used also for diagnosis of pulmonary embolism. A VQ scan has an excellent negative predictive value and can be used in patients who have contraindication to contrast media, but unfortunately up to 50% of patients have non-diagnostic scan, especially if the chest X-ray is abnormal. So what should we use, CT angiography or VQ scan? In a study done on more than 1,400 patients, they were randomized between CT pulmonary angiography or VQ scan, which showed that CT pulmonary angiography is not inferior to VQ scan in ruling out pulmonary embolism. CT scan can rule out other clinical, other causes of the patient's chest symptoms, such as infection, pneumothorax, and congestive heart failure. And in Pipette 2 study, it showed that there's a higher rate of a non-diagnostic VQ scan than CTPA. So about 25% of VQ scans are non-diagnostic, while less than 10% of CT pulmonary angiography is non-diagnostic. So if you want to go for one study, it's probably advised to go for a CTPA, which can be as good as VQ scan, and it has a less rate of non-diagnostic scan. So what are the imaging findings of patients who have pulmonary embolism in CT? So some of the signs used is the crescent sign or the rim sign, where you see the filling defect inside the pulmonary artery and the contrast surrounding it. Tram track sign, if you get the vessel along its long axis, you can see the central filling defect and the contrast going on each side as a line, as a tram track. It's called tram track sign, and this is called the rim sign. Another sign that can be used also is called the polo mint sign. You see the central filling defect and the contrast all around it. The crescent sign, you see again the filling defect and the contrast appears like a crescent at the surrounding the thrombus. Sometimes artifacts may be confusing in CT angiography and can mimic pulmonary embolism. So some of the famous artifacts are streak artifact or beam hardening artifact from the contrast in the superior vena cava, motion artifact, especially from respiration. Many of these patients are dyspneic, and therefore they cannot hold their breath for a long time, and that can lead to motion artifact. Volume averaging from lymph nodes or adjacent unenhancing vessels or lung lesions can mimic pulmonary embolism. Sometimes there's asymmetrical pulmonary vascular resistance due to stenosis or due to interstitial lung disease, which can lead to asymmetric enhancement of the lungs, giving you artifacts mimicking pulmonary embolism. This is another illustration where sometimes you can detect even small subsegmental pulmonary emboli if you do the right technique. Right ventricular strain can be a poor prognostic factor in patients with pulmonary embolism and usually illustrated by straightening or concave interventricular septum. You can see the right atrium is getting larger, the left atrium is getting smaller, indicating right ventricular strain, which can bear a poor prognostic indication. One of the signs of right ventricular strain is also backflow of the contrast from the right atrium into the inferior vena cava and the right and into the hepatic veins as well. One of the indirect signs is differential perfusion, where you see some areas of the lung are less perfused than others. This is not very specific for pulmonary embolism, but it can be seen in patients who have acute or even chronic pulmonary embolism, where you have areas of the lungs having less perfusion than others. Chronic pulmonary embolism can be differentiated from acute pulmonary embolism sometimes, where the filling defect, instead of being central, it becomes peripheral. Sometimes you can see membranes inside the involved blood vessel. Chronic pulmonary embolism can also get fibrosed and calcified. You can see the calcification here in the periphery of the pulmonary artery. Development of collaterals, especially from the bronchial artery around the airways and in the intercostal space, and also along the surface of the diaphragm in patients who have chronic pulmonary embolism. This is one of the new imaging techniques that can be used in the assessment of pulmonary embolism, where using dual energy CT scan, we can assess the iodine distribution in the contrast agents. So IV contrast agents, they contain iodine, and using dual energy scanners, you can detect the distribution of this iodine, and therefore you can assess where's the areas of higher perfusion and areas of lower perfusion. If you look in this image, this is a coronal image. The orange color indicates where there's a higher amount of iodine, i.e. there's more perfusion, and the darker areas demonstrate there's less perfusion. If you look carefully at the left lower lobe pulmonary artery, there's a central filling defect, which explains the lower perfusion in the left lower lobe. One of the new techniques also is ultra-high pitch techniques, which means the scan will be ultra-fast. This can be very helpful in patients who cannot hold their breath for a long time, or in patients or in children sometimes if they don't know how to follow breathing instruction. But the problem with being ultra-fast, that means you have to also more accurate in your timing for contrast administration and scanning. This is a patient who has a tiny left lower lobe pulmonary embolism. The scan was done as ultra-high pitch technique, which is much faster than the conventional imaging. So now we're moving on to the pregnant population. The problem with the pregnant population, some of the physiologic changes, such as shortness of breath and tachypnea, can mimic the clinical symptoms of pulmonary embolism. And the other problem is they are more prone for embolism and thromboembolism more than the non-pregnant population. So that can be more confusing. That can make the issue even more confusing than usual. So back in 2010, the American Thoracic Society and the Society of Thoracic Radiology co-sponsored a project to come with evidence-based guidelines for the assessment of venous thromboembolism in patients in pregnant population. They formed a multidisciplinary panel, and they reviewed the available literature to come with the more appropriate evidence-based guidelines for assessment of these patients. The panel composed of the Society of Thoracic Radiology, the American Thoracic Society, the Society of Nuclear Medicine, American College of Obstetricians and Gynecologists, American Association of Physicists in Medicine, research librarians, ethicists with expertise in fetal maternal health issues. They formulated about 11 questions and try to answer these questions from the available literature to come up with proper guidelines. These questions are: what are the clinical indications for imaging evaluation of patients suspecting of having pulmonary embolism in pregnant women? Should D-dimer be used to exclude suspected pulmonary embolism in pregnant women? What are the risks to the mother and fetus when studies requiring radiation are performed? What are the risks of the fetus when studies require iodinated contrast or gadolinium-based contrast are performed in a pregnant woman? What is the value of a chest radiograph in the diagnostic assessment of suspected pulmonary embolism in pregnant patient? What is the value of bilateral venous thromboembolism, bilateral venous Doppler ultrasound in patients with pregnant patients suspecting the pulmonary embolism? What is the value of lung scintigraphy in the diagnostic assessment of suspected patients with pulmonary embolism in a pregnant woman? What is the value of CT pulmonary angiography on pregnant women suspected having pulmonary embolism? What is the value of MRI in pregnant women suspected to have pulmonary embolism? What is the value of digital subtraction angiography in the diagnostic assessment of patients suspecting having pulmonary embolism? And finally, what is the optimal imaging guidelines for these patients? So they came up with the following recommendations. The first recommendation: we suggest that D-dimer should not be used to exclude pulmonary embolism in pregnancy due to the low specificity and this result cannot be dependent. It can be also falsely positive sometimes. In a pregnant woman with suspected pulmonary embolism and signs and symptoms of deep venous thrombosis, we suggest performing bilateral venous compression ultrasound of the lower extremities, followed by anticoagulation if the study is positive, or further testing if the study is negative. So the first question you want to ask your patient if she has leg symptoms. If she does have leg symptoms, then it's probably advised to do bilateral lower limb Doppler ultrasound to rule out DVT. If it's positive, you can go ahead and treat your patient. If it's negative, it's advised to go for further imaging studies. In pregnant women with suspected pulmonary embolism and no signs and symptoms of DVT, we suggest performing studies of the pulmonary vasculature rather than compression ultrasound. So if there are no lower limb symptoms, it's advised not to waste time and do lower extremity ultrasound. Instead, go and image the pulmonary vessels directly. In pregnant women with suspected pulmonary embolism, we recommend a chest X-ray as the first radiation-associated procedure in the imaging workup. So if you decide to image the chest, the first radiation-associated procedure recommended is chest X-ray. The value of the chest X-ray is to rule out other pathology that can explain the patient's symptoms. For example, large pleural effusion or infection or congestive heart failure. The other use of the chest X-ray in pregnant patients is also to decide, should I go for a CT or go for a nuclear scan? Studies have shown that if the chest X-ray is abnormal, the incidence of a non-diagnostic VQ scan is much higher than if the chest X-ray is normal. So if the chest X-ray is normal, it's advised in general to go for a VQ scan. If the chest X-ray is abnormal, it's advised to avoid VQ scan because most likely you'll end up with a non-diagnostic study, and therefore it's advised to do a CTPA instead of a VQ scan if the chest X-ray is abnormal. In pregnant women with suspected pulmonary embolism and an abnormal chest X-ray, we suggest CTPA as the next imaging modality rather than lung scintigraphy. In pregnant women with suspected pulmonary embolism and a non-diagnostic VQ scan, we suggest further diagnostic testing rather than clinical management alone. And in patients with a non-diagnostic VQ scan and in whom the decision is made to further investigate, we recommend CTPA rather than digital subtraction angiography. So this is a diagnostic algorithm they recommended. This is the same algorithm adopted by the American College of Obstetricians and Gynecologists and the Society of Thoracic Radiology and the American Thoracic Society, which is if you have a pregnant patient with suspected pulmonary embolism, first of all, the first question you ask if she has leg symptoms. If it's present, then we recommend compression ultrasound of the lower extremity. If it's positive, treat the patient. They don't need to image the chest. If it's negative, or if the patient has no leg symptoms, the recommendation is to do a chest X-ray. If the chest X-ray is normal, then we recommend doing a VQ scan. If it's negative, you stop. There's no need to investigate anymore. If it's positive, you can go ahead and treat. If the VQ scan is non-diagnostic, or if the chest X-ray is abnormal, then it's advised to go to a CT angiography of the pulmonary artery. If it's negative, then you excluded pulmonary embolism, and then you can stop. If it's positive, you treat the patient. If the exam is technically inadequate, then you go again and reassess your patient. You might consider doing a compression ultrasound of the lower extremity, or repeating the CT pulmonary angiography if required. So, as you know, because of the risk of radiation to the fetus and to the mother from CT, there are certain techniques we can follow during CT to minimize the risk of radiation. One of them is using breast shields to eliminate the radiation dose to the breast. The breast is a very radiosensitive organ. Lead shielding to the fetus, and also oral barium given to the mother. The oral barium forms a coat around the uterus, which also helps protect the fetus from scattered radiation. Reduction of the tube current and voltage. Increasing the pitch. Increasing the pitch means making the table move faster. That means the scan will be faster, and that means there will be less radiation exposure to the mother and fetus. But again, you need proper timing of the contrast bolus if you want to do a faster scan. Increase detector collimation thickness. Reduce the Z-axis of the scan, so you don't need to scan the entire chest. Just stop at the dome of the diaphragm. You don't need to include the posterior recess. Eliminate the lateral scout film. Avoid test bolus, and eliminate any additional CT sequences. It's also advised to use faster scanners. So if your hospital has a 16 slice or a 64 slice, go for the 64. It's a faster scan. That means there will be less radiation risk to the fetus. Reducing fetal radiation dose, also in VQ scan, can be performed by reducing the dose of the perfusion agent. You can use half dose or even quarter dose if you want to. If the perfusion is if the perfusion part of the scan is normal, you don't need to go for the ventilation scan. You can stop there because the perfusion is normal. You can basically exclude the risk of pulmonary embolism. And if you decide to go for a ventilation scan, you can also reduce the dose of the ventilation scan. The radioactive material can be excreted through the kidneys into the urinary bladder, and as you know, the urinary bladder is just posterior to the pregnant uterus, and therefore, because of the radioactive material in the urinary bladder, it's advised to encourage frequent voiding of the bladder, or you can insert a Foley's catheter during scanning just to eliminate the radioactive material excreted in the urinary bladder. So in conclusion, proper use of clinical prediction rules aids in better utilization of imaging studies and cost effectiveness, but it may not be helpful in pregnant women because physiologic changes can mimic the clinical manifestations of pulmonary embolism. In the non-pregnant population, MDC-TPA is preferred as a diagnostic technique, but in pregnant patients, sometimes you may prefer doing a VQ scan, especially if the chest X-ray is normal. VQ scan with patients can be used in patients who have contraindication to iodinated contrast, such as renal impairment or patients with allergy to contrast media. Dual energy CT scan can depict regional perfusion issues and can help detect smaller emboli. Higher pitch, low dose techniques help reduce motion artifact and can be used in patients with poor breath holding. Some of the guidelines may not apply to the pregnant population, so it's advised to categorize, to approach your patients, to approach pregnant patients slightly differently based on the explained guidelines. And thank you very much.